Hello, my name is Caroline Ryan, and I am the Care Transitions Lead for the Administration for Community Living. The following interview is an excerpt from a recent ACL Care Transitions Peer Hour. Each Peer Hour features an interview with representatives from care transition programs in the field. These interviews focus on strategies that your colleagues are using to successfully build and strengthen transition programs, as well as adapt them during the COVID-19 pandemic to continue to meet increased needs. The goal is to share actionable information and ideas that you can bring back to your own organization. If you have any care transition questions or would like to share your organization's innovation experience, please feel free to contact the ACL Care Transitions mailbox at caretransitions@acl.hhs.gov. That's CARETRANSITIONS at acl.hhs.gov.
Today we're going to be talking to Region 4 Area Agency on Aging in the state of Michigan. And we're joined today by the Chief Executive Officer of the Region 4 Area Agency on Aging, Lynn Kellogg, and the Chief Operating Officer, Christine Van Landingham. And so they're going to provide a little bit of information about a very innovative model that they have been able to launch, deliver, and begin moving towards sustainability in the Michigan market. So thank you, Lynn and Christine, for joining us today. So first, can we start off with, Lynn, can you provide a description of your overall organizations and the programs that you provide?
Sure. Just to put us in context of what kind of AAA we operate under and a little bit about us, we are a private 501c3. Been very stable. It's our 46th year of operation. We take the mission-driven component of the Older Americans Act very seriously, which means we have steady innovation going on to cover our mission fulfillment, which is all about collaborations and partnerships. We're involved in multiple demonstrations at any one time, and happy to talk about this one. We're a relatively small 3-county region, and I'd consider I moved to this area 40-some years ago to God's country here on the shores of Lake Michigan and beautiful rolling farm country, very typical of a lot of areas. We have, as an area agency on aging, we have certainly all the Older Americans Act programs. Michigan has an Older Michiganians Act that clones the Older Americans Act. We also, the AAAs in Michigan, when the Medicaid waiver was coming about, we were the demonstration site, one of 3, for seeing how to structure the Medicaid waiver. So the area agencies are prepaid ambulatory health plans for age 18 and up for nursing home eligible folks living at home. So we have ranged from services from a very frail adult population to one of our newer initiatives a few years back, of the Campus for Creative Aging, reaching out to laud age as a time of creativity, purpose, passion, and ongoing learning. So we try to cover the range there. So that's really who we are in the base. So we're always excited about new endeavors.
Great, and that's an excellent description. We like to really highlight the presentation or description of your organization so other organizations that may be on the line can really see how they compare in the services that you offer and in the market. And so you have been able to implement a very innovative project, and one type of model we've been highlighting is where multiple collaborations occur between hospitals, primary care providers, with area agencies on aging to deliver a unique model of care. So it sounds as though that you all have done that. Can you provide an overview of the types of healthcare partners that are involved in the project that you're implementing?
Sure, and just again, to your comment about how we're typical of others, I'll go back to a brief origin that I think anybody can start, which was way back in the 90s. We started something, our founders started something called Healthy Burying Consortium, and it's a model we've taken on and now have expanded out, where it doesn't do any program delivery, but a meeting of the minds of healthcare providers on a data-driven platform to understand the needs facing the community. And we've had, from that source, which is still strong today, we have an excellent platform for just discussing what data means, how it affects our community, and the providers vary, basically the CEOs of all major health entities in the region. That has been an amazing platform for building strong trust and maybe an environment that allows entities to see a goal together and take some risk of how they might be able to work together when we're talking about new initiatives. So that's how I think some of that richness of that platform has allowed us to speak to a lot of entities. Our current efforts stem back from when we were really looking at how to support people with chronic disease management and also transitional care as people were bouncing around. And it led us to form an initial project called the Interagency Care Team, because we really recognized, we put up a big sticky wall and traced somebody coming out of the hospital with very precarious health of who they might touch in the community. And it was really an eye-opening experience for a lot of people, because we had a lot of the healthcare providers in the room, and it was quite far-reaching. So that helped us realize that people come into contact with so many different entities, and we needed each other to really, because people were going to reach out to whoever they reached out to, family, friends, trusted sources, professionals, to counsel them on their choices in healthcare and life. So that was where we started seeing how we needed to go, and we had the philosophy of, it was beyond coordination. It was, we wanted to build on our own core competencies of the different agencies, but we're all busy. So how do we create a model, prove to ourselves that it works, and then launch that into beyond coordination, to structural linkages that could make that live on into the future. And that's, as you might guess, a multi-year effort to go that far. But that's how we've gotten involved right now with contracts with our major health system, but we contract specifically with their division called host calls, which are their physicians seeing people in the home, and a rural health clinic that we're currently under contract with.
So that's an excellent range of partners. So you have a major health system, and as I understand, that health system is an accountable care organization, or in the accountable care organization program. You have a rural health center that's funded by HRSA, and you have a home-based primary care practice that is also partly owned by the hospital. It
is. It was actually stemmed from an entity that is also a hospice and palliative care organization that merged with the hospital, and over time that the shift of their host calls product went to that organization. So they were independent to start, but ended up being a major link for the hospital system to the home-based world. And we found a common philosophy, perhaps, there of people trying to live at home with serious illness, sometimes end of life, sometimes not. But that was very helpful. In our initial stages with the original interagency care team, we also, the health department has been a major partner all the way along. And for some of our earliest demonstrations, with that product, because to see were we making a difference or not, we had an independent evaluator come join our team and then report to the health department, because they had an excellent epidemiologist. We've had a long-standing partnership with them, as well as being part of Healthy Variant Consortium. So they brought in an evaluator that could look and trace and help us organize what we were doing in those initial years to see if this really made a difference. And I think what happened early on was the folks that actually see people that are struggling have the same goal. They want those people to stop struggling and to thrive. So we found an opportunity there for really connecting that. The results of that study showed definite improvements, and it launched us further. And then we could keep following our paths to think, okay, that was testing something, which I personally always thought that grants and contracts like that sort are good for testing, but they need to lead to something of the broader vision and be a stepping stone. So that was our
Interesting that you mentioned grants. So it really sounds like a robust infrastructure and a lot of partners at the table, including the health department. That's really great to think about evaluation on the front end. How did all of this come together in terms of funding this operation?
Well, early on, when we were back at the Interagency Care Team, we caught the attention of a state foundation, a local foundation, and a private foundation that came together and kind of got excited with us because they knew the key, a lot of the credibility of a lot of the health entities were mutually supportive in proposing this as a cutting-edge way to test how we could work together to make health and lives better for people that were struggling. And so it was originally it was, we had no funding to start. So that's why I say the replicated is not that type if you have a commitment. When the health department, and it was also the mental health agencies and the federally qualified health clinic and the health department, all of those in the initial stages of back to the sticky wall and trying to figure out where we were, thought that we were just doing it with our own staff. Area agencies do program development, work about developing programs. All these other entities had staff assigned to trying to make things right. So we used our existing core competencies until that became, we recognized that this was growing. And then we evolved it to grants for the first demonstration and that testing area with that initial evaluator.
So was there a requirement for you to make this sustainable that was tied to the seed capital that you invested and that the grant funded?
Well, when we approached the grant funders, we were excited about a way to work together permanently. And we made that clear from the onset. One of our goals was to explore payment models that, should this be successful, how would we build that in? So that was a goal from the start. And then it has to ripple up as you get excited about your successes through the various organizations, and you have to answer multiple questions all the way along the way. But yes, that sustainability has been the goal from the start. I think all entities came to it with an interest in knowing more about each other, of how do we stretch ourselves into a new area. And knowing, again, we're all doing this, there's overlap, but at the same time, none of us have enough resources to just take on a new world and do it. So we had exploration of payment models right from the get-go as a goal.
Great. Now I'd like to really explore what those payments models are. So with every great organization, the CEO sets the vision, and then the operator comes behind the CEO and up all night trying to figure out how to make the vision come to life. So now I want to hear from Christine about all those sleepless nights that you had to deploy the model that the vision was laid by Lynn. So Christine, you all have been doing quite a bit of care management and care transitions work as part of this model in seeking sustainability. But what's front and foremost in everyone's mind is the pandemic. So have you modified your delivery model during the pandemic?
Absolutely. The pandemic has accelerated some work, put some on the back burner, and modified every piece of our business, I believe. So pre-pandemic, this was an in-person community-based care management model of care, and that really was what was demonstrated in our early years to be a linchpin was getting that care manager in the home, the eyes in the home, to see what was really happening in the home and do that intensive exploratory work with the patients, with the people we're serving, and with them creating a care plan and bringing services and supports to meet the needs. So with the pandemic, all of that came to a screeching halt in terms of in-person care management at a time when the need for community-based care management went through the roof. So our other in-person work that we had to shift was, this is a team-based care. This is our care managers and the practice care managers and the inpatient care managers working together. So we had a cadence of in-person meetings for the team coordinating care. All of that went virtual. And for the vast majority of the pandemic, we've been doing telephonic care management with participants and team and Zoom care coordination with our clinical partners on the team. We've just launched and are testing 2 telehealth platforms so that our care managers can get the eyes back in the home, even if the boots aren't in the home. And those two platforms that we're using are clinical Zoom for patients who have IT in the home already that exists, that allows our care managers to have a face-to-face, a telehealth care management visit with participants, and for participants who do not have technology in the home, and that is a significant percentage of the people that we serve, we're testing another technology platform and utilizing grant tags for that effort. We've switched to telephonic and Teams meetings for the clinical team, and that has worked really well in terms of the team effort, because we can't miss that component. This isn't just our care managers and the clients and the patients that we serve. It is a team-based model of care. If we get into the sustainability model and the codes that we're dropping, it has to be a team approach, not a siloed effort. So making sure that in this time apart, that we bring the teams together electronically has been a key focus as well.
So there's a lot of great innovation there that I want to highlight to all the participants. So you're doing a team-based care management model that includes care transitions and care management.
Right.
We're doing a heavy in-person delivery model that then went virtual. And now you're integrating telehealth or telecase management and testing that using a couple of telehealth platforms, clinical Zoom being one, and then with GrandPads being the other. So that's excellent. Now, you mentioned the team-based care. Since you're working as an extension of the care team, is the entire clinical team, including the area agencies on aging partners in the delivery, are you on one unified technology platform? How are you addressing those all-encompassing technology challenges for integrating community with clinical?
Absolutely, and I'd say that's central to any plan is solving this issue. And early on, before we executed contracts, we were simply guests in their system. We were able to access Epic Care Link, which allowed our team to have read-only access to the electronic health records, and then the team utilized, by team I mean our broader partners that Lynn talked about, the FQHC, the health system, the AAA. We used a workaround, a communication tool that was a HIPAA-compliant web-based communication tool that sufficed for that pilot project while we were testing our intervention and proving its worth in terms of reducing costs and improving health, which led to, once we were able to prove the intervention, which led to our ability to execute contracts with the practices. And once we are acting, as you said, as an extension of that practice, our care managers are functioning just like their employees of health calls or employees of the rural health clinic. So they have direct access into that instance of Epic. So what they have full access to charts, to care collaborate with the full team on the clinical side as any other care manager inside of that practice. And I would say that that has been a linchpin to solving some of our IT issues. Doesn't solve everything, but that got us a long way to being able to address the clinical care coordination as well as some of the other IT issues.
So that's really great. So you mentioned contracts, which piques everyone's interest, as well as really being part of the care delivery team. So do the contracts that you have enable reimbursement back to your agency for the delivery of services that are tied to billing codes and reimbursement?
Absolutely. So as we developed and executed this contract, we looked at both the codes that we expected to use right out of the gate and the codes that that the AAA could provide in partnership, recognizing we wanted to develop a holistic menu of services that we could do collectively to impact the health of our community and not have to go back and keep adding addendums. So the contract does spell out specific codes that we're operating under and does allow for the health system to drop the code and then reimburse the AAA for the services rendered. And it spells out, there's a small percentage that the health system retains for that billing service, but then reimburses the AAA for the balance of codes and revenue collected under those codes.
Great. So I know one thing that's probably top of mind for a lot of people watching is the type of staff. So this is a common question that we receive. If you're delivering these services as an extension of the care team, is the entire agency staffed with RNs, or what are the types of staff that you have that are able to functionally deliver services as part of a care team that leads to reimbursement?
Sure. So we are using RNs and social workers for this service, for the chronic care management service. We can also use community health workers. We're currently not using that model, but as we look at increased capacity and staffing challenges, we are also looking at what are those other levels of credentialed staff that we could utilize. But currently, we're using RN and social workers for this service.
Great, great. So you're getting reimbursed along with the provider based on billable services. So it sounds like, just like there's a joint clinical team, from an administrative standpoint, there likely is a joint team that's making sure that we're billing and collecting. And so what role do you all play in ensuring that the provider is able to bill and collect for the services upon which you'll be reimbursed?
Absolutely. So the operational side outside of the clinical side is key in terms of, and I would say it's just as key. If you can't get paid for the service, you're not going to be able to continue to do this great work in the community. So documentation is key. Our staff are trained to know the required elements for each code and to ensure that the patient's electronic health record reflects all of those activities, ensures that the care plan is shared and that the provider signs off on it, that care coordination elements are all there. So if it's not documented, it didn't happen and we're not going to get paid for it. So it starts at the front line, making sure our care management staff is highly aware of what they need to chart inside the patient health record. So I would say, I would circle back to my previous comment, the ability to document directly in the health record, electronic health record is key. If you rely on your partners to document our work, if we're just submitting data for them to then put into the patient, we miss many opportunities. So I'll just reiterate that point. Make sure that that's central to your plan. And then they have a team, and they have a dedicated staff person, and we have a designated staff person, as do we on the finance side, to we document our time, submit the documentation in terms of time spent for each of those codes. Our health system then bills it, and then there's some reconciliation on the back end. When the health system receives their payment, they send us a spreadsheet that says these are the patients and the codes for which patients were dropped, and this is what we were reimbursed. And then we do a little bit of a deep dive, some analysis. Why weren't some paid? What were some of the blockages? And then that provides us an opportunity to do some analysis on that so that we can look for trends and we can summarize that data and then inform any needed adjustments to service patterns or documentation to maximize reimbursement success rate. So it's a team effort, and our just like relationship on the clinical side is important, relationship on the operational side is just as important, so that their finance person and our finance analysts on our side have a great relationship so that they can reach out to each other and really look for opportunities to have greater combined success.
Wow, so almost as if you all are really operating as one agency, delivering services in unison, you're reconciling, you have full view into the billing and collection. So obviously this is a relationship that's been built over time, but you put in the work to get to this point and now definitely reaping the benefits. So that really is excellent. So my next question is really for both Christine and Lynn. Is the population that you're serving limited to the Medicare fee-for-service population, or are you also seeking to include other payers such as Medicare Advantage or even dual-eligible special needs plan beneficiaries?
So it's interesting because I would have answered this question differently in the beginning. Our target, we thought we would be serving Medicare fee-for-service. And when those reconciliation statements started coming back and we saw the reimbursement rates were different, our health plan, our health system partners said, yeah, well, we're including additional patients and additional payers. And so they broadened our scope quickly. And so we do also serve beneficiaries who have Medicare Advantage plans.
And I would add that when we went off from the interagency care team and moved into a payable model structure, the benefits are become somewhat obvious. The other thing, there's limitations because of those payment codes and the structures. We really have to kind of own each other's world and recognize that if somebody can't, help each other figure out those barriers. And so Christine talked about how that becomes an attitude thing. And it really is helpful. I would say that about the payment sources and the target populations as well. We start with one population and then we see we want to go further, and the whole world keeps shifting. That's why we contact you, Tim, now and then to understand the shifting world out from us. And we've also had some of our partners attend N4A with us, and we've in turn attended some of the complex care sessions to try to learn what is the cutting edge, what are the new opportunities. And as we see this as a partnership that could reach to so many populations, where can we find additional demonstration possibilities for, that's why I say it's never done, because then you don't want to turn down someone just because they didn't have the right insurance structure, so that's a moving target, I believe, and the focus on is really pretty much 18 and up, to just focus on people that have pretty serious markers that are in distress in terms of their health. And that was another key too, helping each other understand what defines success for the person always, and then the behind the scenes of the operations as well.
So one kind of operational question: how do you go about securing referrals? We often hear that organizations, they get these relationships, but then the referrals don't come. So how are you securing and tracking referrals?
That's an excellent question, and that's been a relationship road as well. Once we execute the contract, you have to have the top of mind awareness, so that as physicians and care managers and practice managers are seeing patients, we're not relying on just them remembering to refer to this project. So a key phrase for us in our partnership and project development has been structural linkages. So how do we hardwire in best practice alerts, BPAs within the electronic health record, and where are those triggers for so that our clinical partners will think to refer, and then what are the relationships that we have to nurture with that. So our current practice is that our practice managers, and in this case it's with 2 different practices, works with their internal care management staff and providers to identify patients based on some risk scores, and that is discussed at the weekly team huddle, which includes the AAA care management staff, and that goes back to that relationship and making sure that that's hardwired in. It's not just that somebody knows someone, but that we have a structured time to connect on this particular project. So that's how we secure referrals, and we track them through an internal SharePoint site that allows us outside of the electronic health record to track where those referrals are coming from, what was the status of each, and where we are in terms of volume.
Great. Now, one of your partners is a home-based primary care provider. And I've often thought that home-based primary care providers and kind of the mission and vision of area agencies on aging is closely aligned in supporting at-risk, vulnerable, older adults and persons with disability in the community. So the home-based primary care practice is owned by Lakeland Health System, and it's called House Calls. It also does palliative care. So are you finding overlap between the beneficiaries that are served by the practice and beneficiaries that are currently involved in one or more waiver programs for long-term service support in the state?
So we already were highly aware of where our populations, our patients and clients overlap. We have a census at any given time of over 650 Medicaid waiver clients. As Lynn said, we are the My Choice Medicaid waiver agent here in Southwest Michigan, and House Calls is the primary care provider for a significant percentage, not the majority by any means, but a significant percentage of those patients. So we were already working collaboratively with House Calls on those. We do find that House Calls is a strong referral to the My Choice waiver because they see such benefit to their patients who are enrolled in that program. So as such, because we have such a close tie, one, we don't see a lot of crossover in terms of referral for our chronic care management versus our Medicaid waiver. And I will say that as with any referral to this program, whether a key component was this being the AAA as this partner in doing chronic care management and the other billable codes that we're working with our health partners is our INA, the connectivity to our INA team, so that every patient, every person that's referred to us through any of these contracted services has access to that unbiased information and assistance and referral to the full menu of waivers or other community-based services, any other community service to which they're entitled. So if to go back to Lynn's sticky wall comment, where we did this whole roadmap of where a person with serious illness or chronic conditions that are not well managed might intersect with opportunities in the community, this brings that all under one model and one umbrella and creates, again, that structural linkages that provides those patients to have access and get linked to the right service based on their needs and preferences within the community. That might have been more of an answer than you were looking for, but I could get on my soapbox there.
No, that's an excellent description. I think it's something that we've been advocating for. So through this partnership arrangement, your agency now is part of the care team. There's a defined pathway to reimbursement. There's open transparency on what is billed and collected, and you're working together to draw down reimbursement. And when possible, you're able to connect those persons to the ADRC and all the other services that are available as the Area Agency on Aging to enhance the mission of both organizations to meet the needs of the population. So that really is an excellent way to leverage the strengths of both organizations to achieve mutual success. We really applaud that. And so knowing that missions are aligned and you're have an evaluation team through the health department where you're able to look towards reducing the total cost of care. Since I mentioned that at least the hospital is part of an accountable care organization that is one of the Center for Medicare, Medicaid, and Innovation alternative payment models, and one of your other partners is also engaged in an alternative payment model, are you also looking at the ability of your interventions to lower the total cost of care for the population?
Absolutely. From inception, our work has focused on developing tools for tracking total cost of care and the intervention impact on cost reduction, both cost reduction and health improvement. Access to data is a key challenge. It takes a manual pull on the health system, on our health system's partners' part, and then data analysis is a collective effort. What we've been able to do right now, and it's been impactful, is analyze the cost of care in terms of health system charge data. At present, we don't have access to CMS claims data, so we're limited in that regard. But the unit, we're a little bit of a closed system here in our small community. As Lynn said, one of our borders is the lake. So we're a bit of a closed loop in terms of if people are going to a provider, most of them are inside of this health system. So we can see what were the charges and the costs 6 months pre-intervention and post-intervention. And our markers have been, we didn't necessarily talk about who we're targeting. We are targeting people with multiple chronic conditions that are not well managed, people with serious illness, and people who are frequent utilizers of the emergency department and experiencing perhaps unnecessary, but certainly frequent hospitalizations. So we looked at the charge data 6 months previous and 6 months post, and we're able to show remarkable, significant cost savings in that regard, and that led us to be able to get to these contracts. Our next iteration, as you said, one of our partners is moving into some alternative payment models and is just secured and will be beginning the primary care first model January 1. So we'll be altering our current contract, which is based on a fee for service. We do this service, they drop the code, we get paid. In the primary care first model, that's an all-inclusive payment. It's a different kind of payment model. So we'll be modifying our payment for the services rendered and looking at the quality bonus that the practice is working toward getting and sharing that bonus with the AAA, because as we contribute to those quality markers and cost savings, there's an acknowledgement that needs to be reimbursed as well, not just the fee for service. So we're excited about finally moving into recognition, documentation of cost savings, recognition of our contribution to quality, and then reimbursement and a sharing of those rewards in terms of the ability to share in that quality bonus.
That is great. So you've been able to really highlight the potential return on investment by implementing hospital home transitions, extended care management services, and now have the potential not only to be reimbursed for your services as part of the claims process, but also participating in potential shared savings with the provider group. So that is excellent. So
if I could say, Tim, we also recognize it's built-in shared risk. We built in our first contract. If the health system didn't get paid for the codes that they dropped, we didn't get paid. So it's a shared risk reward. This is a relationship. So I want to make sure that we acknowledge that we built that in as well.
Great. We're close to time, and we want to allow questions to interact with our great panelists. And so just lastly, want to end with this part of the presentation to say, are there any things that either one of you would make as a recommendation to other programs that are seeking sustainability through contracting or contemplating establishing this type of relationship with their healthcare provider partners?
I would offer a couple things. One, it is largely about relationships and looking at data. I think finding the places where people's pain points, mission, their drive, where they intersect is the place that you really can start clicking. Our initial group met for 2 years without outside funding, and they insisted on every other week because we were learning so much. So it was like, that's a huge factor. I also was thinking of in the nursing home diversion and transition work, we've had to put structural linkages in places for what we already did do. We wanted to expand service and funding sources for all entities, but we also, at the same time, something like the Medicaid waiver and some of the traditional services weren't acknowledged. So we wanted to create those structural linkages for those too. That leads to only more and more trust as you prove yourself with those, which certainly now with COVID has really ballooned on us in terms of turning to us more and more and more. So I see the environment for partnerships strong, and I think it all goes back to what we use commonly in the aging field, person-centeredness. If you find the people that truly want to make this work for their patient, person, whatever participant, that's where the connecting passion will come, when you can realize you can make that work together.
I think those are really great points, Lynn. In addition to the structural linkages, the relationship, I think it's tenacity in terms of don't give up on this. We've been at this. Gosh, I don't know. I might guess, but I might get it wrong. But I think it was 2012 when we started meeting with those biweekly, every 2 weeks, meetings. So we did that for 2 years, and it just, it accelerated the pace, but it laid a strong foundation. So be tenacious, don't give up. These are good partners on the other side. Assume goodwill and keep at it.
Thank you so much for listening today. We appreciate your time. We also want to thank our speakers for sharing their experiences with all of their peers on this Care Transitions Peer Hour. If you have any questions or would like any direct support from our technical assistance team, please reach out to the ACL Care Transitions email at caretransitions@acl.hhs.gov. Thank you.